Okay, good evening, everyone. Welcome to another female athlete webinar series. There is a little bit of feedback coming there. There we go. That seems to be working. So welcome, everyone. I hope everyone is well tonight. Maybe just drop in the chat and let us know where you're joining us from. I mean, we've essentially got all kinds of corners around the earth already. I'm here in very hot Pretoria. Kuyashisa Kakulu here in Pretoria, which means it's very, very hot. And then Dr. Phatho's joining us from KZN, and then we've got Dr. Kate Ackerman from Boston. So I see there's a couple of people joining. There's Jane from Edinburgh, got from Morna from Scotland. Sandra's here from Cape Town. See all the Gauteng people are hiding away from the heat at the moment. But yeah, keep us up to date with where you're from. We want to keep this as interactive as possible. We will definitely be taking some questions, if not through the presentation, but we'll do a very comprehensive Q&A at the end. And maybe just to introduce myself, sorry, that would help. My name is Shona, and I'm head of athlete success at Coach Perry. And if you've joined us before, you would have then also got to meet Dr. Phatho. Dr. Phatho Zondi, the sports and exercise medicine physician. She's an avid runner, and I always like to say that she's a mountain biker second and a runner first. Her clinical expertise is in injury prevention and management, and this has allowed her to join South African Olympic Games or teams to the Olympic Games and Paralympic Games and Commonwealth Games. Yeah, she's holds many leadership roles in many different positions and has been awarded a recognition award by the South African government for her contribution to advancing sports in South Africa. So welcome back, Doc Phatho. Nice to have you here.
Thanks, Shona.
Thanks, Doc. And I guess where we sort of came up with or wanting to dive deeper into this Reds discussion, you know, Doc Phatho and I had a discussion around the first webinar we had, and we just felt we didn't go into enough depth in the discussion, and so that's why we decided to bring Dr. Kate Ackerman with us, and Dr. Ackerman is a leading world expert in female health, and in particular Reds or Red-S. And so Dr. Kate Ackerman is a sports medicine doctor and endocrinologist. She's the director of the female athlete program at Boston and is the assistant prof at Harvard Med. She's also the team doctor for US rowing. So Dr. Ackerman, thank you so much for joining us as well, all the way from Boston. Brilliant, thank you. Yeah, I know you're in between patients and children and all of the above between the two of you. And so this is, we're really, really lucky to have you. So, and I know you're not a stranger to presenting in South Africa. And so, yeah, we're very, very honored to have you here. So, and again, I think the focus of tonight, and I don't want to do too much talking because it's really about the two docs who are going to take us through this. There is going to be a little bit of science. And so I'm going to ask you guys to hang on with us, and part of that reason is that we really want to empower women and female athletes to start understanding their bodies and their training and really get the most out of that. So Doc Ackerman is going to do a little bit of a presentation. We'll take a few questions through that, but we'll definitely take a couple after hers. And then Doc Phatho's got a couple of the questions that came up in the last webinar, and we're going to just dive quite deep into those. So keep the questions coming. We've got Brad in the background. He's flagging those for us. And so we will pull those up, and we want to keep it as interactive as possible. So there's a slide just explaining everyone. I should have put that up when I was introducing everyone, but we're getting along here nicely. So what I'm going to do is I'm going to hand over to Doc Kate. If I can, yeah, there we go. You are good to go. And yeah, really, really excited to learn a little bit more about this relative energy deficiency in sports. So thank you, Doc Kate, for taking it away.
Okay, so let me see if I can control my slides here. I'm trying to collect. Do I just hit enter, or do I do the down arrow?
The click should do it.
Oh, wait, here we go. There we go. Okay,
good to go.
So basically, we're just going to start with the history lesson here. And when we talk about relative energy deficiency in sport, it's really based off of some work that was done a long time ago in the 80s and the early 90s. And in the early 90s, the American College of Sports Medicine got a working group together because they noticed that there was this combination of things happening in women. A lot of female athletes were getting eating disorders or were under fueling, and then they were losing their menstrual cycle, and then they were breaking bones and getting diagnosed with osteoporosis. So this original working group came up with a term for that and called that the female athlete triad, tying in eating and menstrual function and bone. And so by 1997, they came up with a position statement about the triad. It was originally just that extreme components over to that bottom left-hand corner. And then by 2007, they said, you know, most athletes aren't really all the way over to the left. A lot of them are on a continuum, and they might have some subclinical menstrual dysfunction, or they might have some disordered eating, but not have a full eating disorder, or they might just not be fueling enough for their sport. And so we want to catch athletes on this continuum before they go all the way over to the left. And it may be that they're just starting to have these issues and not all three of them are coming out yet. So in an ideal world, our weight-bearing athletes would be up in that top corner of that spectrum, where they have optimal energy availability, their bone density is better than a non-athlete's, and they have normal menstrual cycles. There we go. So by 2014, the International Olympic Committee decided to update that concept of female athlete triad and said, yes, there's definitely a triad. We see that in women, but there are also other health and performance consequences. And we can also see that relative energy deficiency happens in men as well. So their triad update in 2014 described this concept of relative energy deficiency in sport, REDS or RED-S. And then in 2018, there was another update about that position statement. So when we talk about RED-S, we're talking about the different health consequences and performance consequences. And there are these two spoken wheel diagrams, and you can see in the health consequences diagram, you still have the triad, you still have this low energy availability, menstrual function, and bone. But then as you go around this diagram, you get endocrine dysfunction, you get changes in metabolism, you get changes in the hematologic system, you can have effects on growth and development. There can be psychological issues where psychological effects happen to affect energy availability, and low energy availability can also affect an athlete's psyche. There are cardiovascular effects, GI issues, and immunologic dysfunction. And then when you go over to the performance effects, this is one part of REDS that I find very helpful with my patients, because a lot of my athletes don't want to be thinking about their hematologic system or if they're going to get osteoporosis later, but they want to know how they're going to perform and if energy availability has an effect there. So if you start up in the right corner, again, here you have increased injury risk, a decreased training response, impaired judgment, decreased coordination, decreased concentration, irritability, depression, decreased glycogen stores, decreased muscle strength, and decreased endurance performance. So here you have athletes who are working really hard, sometimes training 2 or 3 times a day. And if they're not fueling enough, they're not getting what they need out of their training, and they're going to get injured, and they're actually going to get slower. So a lot of this is based on some work that was done a long time ago by Ann Laux, who was at the Ohio State University. And she looked at recreational adult women, and she determined this cutoff for energy availability. So energy availability is defined as the dietary energy intake, so how much an athlete is eating, minus their exercise energy expenditure, so how much they're burning when they go exercise, and then normalized to fat-free mass. And that part of the equation can be hard, but you can determine fat-free mass, for example, by a DEXA or a bone density scan, where you can determine bone and muscle and take away the fat component. So let's say you have an athlete who eats 2,000 calories a day. She goes for a run, she burns off 600 calories. Her fat-free mass is 51 kilos. Her energy availability would then be 27.5 kilocalories per kg of fat-free mass per day. So what Dr. Laux and others found was that 30 seemed to be a bit of a magic number for some people. So below 30 kilocalories per kg of fat-free mass per day, there was often a change in hormone levels, a change in menstrual function. But as we've done more work since then, we realized that 30 isn't a magic number for everybody, and that actually maybe 45 may be ideal for a lot of people, particularly adolescents. But this is really an individual number. So some people won't lose their cycle below 30. Some people can get away with having an energy availability of 28, whereas other people need to have an energy availability of 45. But there is likely a sweet spot for a lot of people. And so when we talk about low energy availability, we have to be aware that there's eating disorders like we see in the DSM-5 or a psychological diagnosis book. And that's really abnormal eating behaviors, an irrational fear of gaining weight, false beliefs about eating, weight, and shape. But then there's disordered eating behaviors, and that can just be a lot of different things that we can see in athletes. So people who fast, people who are taking different diuretics, people who are skipping meals, people who might binge and purge or don't really fit the full diagnosis. And we know that the prevalence of disordered eating and eating disorders is higher among athletes than non-athletes. The risk is higher in females than males, and there's a higher risk among athletes in leanness sports. So things where someone might have to weigh in, or sports where people have an aesthetic component. And we know that eating disorders can be a deviant overconformity to the sport ethic. So what's the sport ethic? An athlete makes sacrifices for the game. The athlete strives for distinction, accepts risks and plays through pain, and accepts no limits in the pursuit of possibilities. So these are people with A personalities who are really driven, really motivated, and you can see how an eating disorder could become an overconformity to that. So what's the prevalence of low energy availability or eating disorders? Well, it depends how it's asked and who you're asking. So somewhere between 15 to 62% of female high school and collegiate athletes have disordered eating. So when these studies were done, sometimes it was a self-report, sometimes it was straight up, just raise your hand if you've had disordered eating. Obviously, people are not going to self-report as much in that consideration. It depends what questionnaire was used and who was doing the questioning. Was it a coach? Was it a therapist? Was it truly, truly private? So we did a study in our clinic, and we basically surveyed 1,000 female athletes who came in for various issues. And we used surrogate markers of low energy availability or disordered eating. So there was just a question that said, do you have disordered eating or an eating disorder? We used a questionnaire called the Beta Q, and that is a brief eating disorder questionnaire for athletes. And then we used the ESP, which is a primary care eating disorder questionnaire. And we had about an 85% response rate. And you can see from the Venn diagram over on the right that it does depend how you ask people, because they have different ways of communicating and they might answer differently. So people that answered yes to all three of those things, you can see it was only 68 of our 1,000 patients. But if we counted somebody as having an eating disorder or disordered eating, if they answered at least yes to one, that was almost 50% of our athletes. So almost 50% of our female athletes reported yes in one of those ways of questioning them about disordered eating. So we know that this is a significant problem. And what's the age of onset? Well, adult elite athletes diagnosed with disordered eating or eating disorders report having started dieting and developing problems during puberty and adolescence. This is a time when females especially are experiencing rapid changes in body composition and shape. They're getting more serious about their sport. They're exercising even more, and there's a lot of pressure on them. So when we focus just on the triad part of REDS, people used to think it was just about a negative energy balance disrupting these hypothalamic pituitary ovarian axis hormones. So they thought if you don't eat enough, that's going to decrease your estrogen, and that's going to lead to low bone density. And that's partially true, except it's a lot more complicated. So when somebody starts dropping below an energy availability of 30, Ann Laux and her group found that there were changes in LH pulse amplitude and frequency, and LH is responsible for what's happening down at the ovaries. So you can see this response relationship, this dose response relationship at 30. However, as energy availability dropped below 30, there was bone protein synthesis and mineralization that decreased. Insulin, which we know is important for amino acid uptake, decreased. IGF-1, which is a form of growth hormone, decreased, and thyroid hormone decreased. And all of that happened even before there was a reduction in estrogen. So there are other hormones that are at play besides just estrogen that are affecting bone. And you don't need to memorize this, but this slide just gives an example of all the different things that can be disrupted. So everything in green is really good for bone, and everything in red is really bad for bone. And when someone is in a state of low energy availability, all of these things are disrupted. And so you can see they're all moving in the wrong direction. And this is another busy slide. If you're interested to know what are the patterns we see in both women and men, this is a review article that we did a few years ago just to demonstrate what's happening in females and what we know so far in men. So men have not been studied as much regarding REDS, but we do know that they can have decreases in testosterone. They also have a decrease in their metabolic rate. They also have a decrease in leptin like women do. Oxytocin and insulin move in the same direction as they do in women. Thyroid function decreases. And while IGF-1 goes down, growth hormone actually goes up. And the reason for that is there's more growth hormone resistance. So it doesn't work as well. It's not as effective at the tissues. So we see all of these changes can happen, and we think in men, they probably need to have an even lower energy availability than women do to see these disruption. So just to go through a few, and not to bore you, we'll just touch on the thyroid and to kind of prove this. So when you look at the thyroid and the studies that have been done there, in 32 subjects that were just looked at cross-sectionally, they looked at amenorrheic athletes who didn't get their period because they weren't eating enough, eumenorrheic athletes, people who got their periods, and then healthy controls who weren't athletes. And the thyroid hormone T4 and T3 was lower in those amenorrheic athletes than the other two groups. So TSH is a hormone that comes from the pituitary, and it's stimulated by the hypothalamus. And so when they looked at those three groups again, a different group of subjects, but the same idea, amenorrheic, eumenorrheic, or healthy controls, they found when they tried to stimulate the pituitary with thyroid releasing hormone, it was blunted in those amenorrheic athletes. And then finally, they looked at just eumenorrheic non-athletes. They looked at women who got their cycles, and they played with their energy availability. They actually changed the energy availability levels, and they found that as they decreased energy availability, there were predictable levels of T3 and free T4 that went down, and an increase in T4 and reverse T3 that went up as people got more energy restricted. So there was a distinct pattern that could be seen as the people were decreasing their energy availability. To just talk about the hematologic system, we talk a lot about ferritin and iron in female athletes in general. So you can have a decreased iron level when you're not eating enough red meat or not enough iron-rich foods. You can have an increased iron level when you're an endurance athlete and you have an higher turnover of red blood cells. You can have decreased iron levels when you're a runner and you have foot strike hemolysis, so the red blood cells break down when you're actually hitting the ground. And then, of course, you can have a decrease in iron when you get a menstrual cycle. So it's interesting that reds and the hematologic system actually run together. Many athletes with reduced energy availability have iron deficiency, and we know that iron deficiency can worsen that hypometabolic state, that low metabolism state. We actually need iron for synthesis of T4 to T3, and that's, again, thyroid hormone, and T3 is really important for the body to work correctly. Iron deficiency may also promote energy deficiency, and we need iron for reproduction function, so follicular development. We also need iron for bone health. So there are a lot of ties there, again, with the iron deficiency and low energy availability. Growth and development. So we know that if somebody is not eating enough, they could actually just flatten out on their growth curve. And that's why REDS is important to watch for in adolescence. So you have these young athletes, particularly gymnasts or dancers or people that are trying to stay a certain size while they're trying to perform in their sport. There's also people who aren't getting enough calories because they don't have access to the food. So there's food insecurity issues. And what we see in these athletes is they grow to a certain point and then they may plateau in terms of height and they may actually dip in terms of weight. So this is an example of a growth chart of a dancer that I saw who really didn't want to go through puberty and didn't want to get any taller and didn't want to develop because she thought she was just the right size to be a prima ballerina. So potential performance effects, I'll just give a couple examples here. We talked about the circle, but this is a study I think is really, really informative that I like to break down for some of my patients. So this was a study of 10 junior elite female swimmers. They were 15 to 17 years old, and some of them had their period. They were the cyclic ones. Some of them did not. Those were the ovarian suppressed, and that was determined based on their estrogen and progesterone levels. And they looked at these two groups and they monitored them every 2 weeks for 3 months or 12 weeks. The ovarian suppressed, appropriately as predicted, had low estrogen and progesterone throughout the season. They had a decrease in T3, that thyroid hormone, and a decrease in IGF-1, that form of growth hormone, at 12 weeks. The cyclic ones did not. The energy intake and energy availability was lower in those ovarian suppressed. And most importantly, the ovarian suppressed had an increase in their swimming time, while the cyclic ones had a decrease in their time. So basically, you have these two groups of athletes. They're doing exactly the same training. They train for 3 months in exactly the same way. And those who didn't get their period were eating less and they got slower. And those who did were eating appropriately and got faster. And so that's just an example of if you're doing all the training and you're not fueling, you're actually getting worse. When we asked our athletes, those that we surveyed, we found that there was a 1.5 times greater odds of decreased endurance performance in those in the low energy availability group versus the adequate energy availability group. So how do you diagnose it? You really need to have a suspicion, and you need to be looking for this all the time. In the last year, there have been some articles that have come out about famous athletes, which has really helped put this on the map a little bit more, particularly in the US when we had Mary Kane speaking out and we had Molly Seidel speaking out and talking about what they went through with their coaches and what they went through their own eating issues. So as a coach or as an athlete, you want to suspect that there might be low energy availability if there's menstrual dysfunction, if there's some disordered eating patterns that you're noticing, if somebody's had weight loss or a low BMI to begin with, change in mood, change in performance, if you can notice a delay in developmental sexual characteristics. So if you've got an adolescent who's just plateauing and not really going through puberty, and then of course an injury. So stress fracture or another bone injury is certainly a red flag. Workup, that could be a whole other talk, but basically this is where it takes a lot of different people helping with this. So getting a dietary history, working with a sports dietitian, finding out about the training plan. I often have athletes who have a high school coach, but then they also are doing extra training, or somebody that just doesn't have confidence in their training plan is just doing extra workouts on their own. Do they have other medical conditions? Is there a family history of eating disorders or other things that should be red flags? Has this person ever gone through menarche? Did they get their period by the age of 15? What other stresses are going on in their life? Are they on any medications? And then there are a lot of labs and different tests that we can do and cardiac testing that we can do just to see how safe the athlete is to be competing or participating while we're trying to improve the energy issues. So I would say as a medical professional, we can often spot it. I have people come and see me all week long, and I can see an athlete as they're coming in the door to almost know what's going on. You know, sometimes we're wrong, but we can have this sneaking suspicion. But what I really need to do is convince my patient that this is important and this is actually going to affect them long-term and short-term. And so that's when some of the testing actually can kind of prove the point. So amenorrhea, low FSH, LH, estradiol, if all of those things are suppressed, it's probably related to low energy availability. In males, decreased libido or low testosterone, often a low white blood cell count or low iron or ferritin or T3 like we talked about, low vitamin D, changes in lipid panels. So there's a lot of different things that we can see. And those pictures on the right are actually the color scans that we can get from a DEXA or the bone density scan. So at the top is a female, at the bottom is a male, and both of them kind of look like Spider-Man. Both of them are red and blue. Fat is yellow, and you can see that there is very little fat on that person. So we have athletes coming in and they tell me, well, you know, my body composition is fine. I look like a typical runner. And when I show them these pictures and show them that they have no essential fat on their body, sometimes I can get them to kind of change their mindset. Well, actually, you do need fat for your cells to function. You do need fat for these different hormones to work correctly. And so I can use that body composition from the DEXA sometimes. The treatment, as I said, is really interdisciplinary. You want to have a really understanding coach. You might need a support group. An exercise physiologist can come in handy, but the basic treatment really needs to be a physician and a dietitian and often a therapist. And then everything on top of that is fantastic. The more people you can get involved in the treatment, the better. I think there are a lot of future directions we need to go with REDS. We need more studies of the other health and performance effects in both females and males. We need more studies determining the efficacy of the return to play protocols, who should be participating when you're trying to get them better, how much training load can you give them, different treatment approaches for eating disorders and disordered eating. So should someone have complete exercise restriction, or should we just decrease the exercise while increasing the calories? I tend to use an approach of, if the person is starting off not medically unstable and they seem to be compliant and taking direction and making good progress, then I don't want to take exercise completely away. I want them to be able to participate. And then psychotherapy early is typically helpful. A lot of times people are developing eating disorders and disordered eating for a variety of reasons. And so getting some sort of therapy, whether it's cognitive behavioral therapy or family-based treatment or whatever it is, can be very helpful as part of this. We still need to do more definitive hormonal studies. We need to be looking at further research of energy deficiency in different types of athletes, and certainly more awareness and preventive programs. So that is all I have. And now I think Dr. Zondi is going to give us a talk as well.
Thank you. Excuse me. Sorry. Thanks, Dr. Ackerman. maybe, I mean, there are one or two questions coming through, which are awesome, but I know Doc Phatho is going to dive into particularly around menopause. And so, but maybe just from one aspect, because I mean, that was very science heavy. And I mean, I love that as a sports scientist. But we put up a poll here. And so just saying on average, how much time do you spend a week training? So that's everyone who's on the webinar. And I mean, for the most part, 57% looks like they train from 5 to 8 hours a week. And so I guess a practical question would be aside from those few symptoms or ideas that you put up, but would someone have an idea that they are reaching into sort of low energy availability and picking up those risks? I think maybe if we can just emphasize some of those symptoms that you had mentioned there previously.
Yeah, so I think the volume of training that the majority of people are responding with, I think is fine. 5 to 8 hours is completely reasonable and healthy. It's really if you feel like you're exhausted before your next workout, if you're not giving yourself good recovery time, if you're not coming up with variability to your training, is it all super high intensity all the time? Do you take a day off every week? Things like that are just kind of a starting point. And then I can't emphasize enough the importance of working or at least meeting once with a dietitian to see if you're kind of hitting the mark. If you're in a premenopausal age range, you should be getting a period every month if you're not on birth control. And so if your periods are becoming irregular, that's a major sign. And if you're feeling just a lot different or more dragging after workouts and you're not feeling that recovery, then that's also a really good sign.
So any questions from your side that maybe you've picked up or that you want to take before we jump into yours?
There was a great question that I think is actually best directed to Kate or Dr. Ackerman,
okay.
rather.
Yeah.
Am I jumping a little bit?
No, go for it, please.
That can be directed rather to Dr. Ackerman, related to adrenal insufficiency. So one of the participants commenting that she feels extremely fatigued because of adrenal insufficiency. And we know that fatigue is a common symptom. So perhaps a question being really could the two relate? Could the two exacerbate each other? Maybe that's something you could shed some light on, Dr. Ackerman, as an endocrinologist. We can hear you.
Oops, I can't hear.
Did you hear Doc Phatho's question?
No, I couldn't hear anything. I could see your.
Okay.
Just really quick.
Yeah,
a question from one of the guests on the show today, asking about, or rather commenting that she has adrenal insufficiency that makes her feel very fatigued, which we know is one of the common symptoms, but perhaps just to ask if there's any relationship.
I don't know why we seem to have, she's lost her sound, or she can't hear us, which is weird.
I can hear you. I can't hear Phatho.
Okay. I will ask the question. Phatho, you're going to, Doc Kate's going to be in silence when you're presenting, but Doc Kate, there's a question coming through from the audience, from Mariam, and she's saying she has adrenal gland that's not functioning 100% and is making her really, really tired. And I think Dr. Phatho was saying that your role as an endocrinologist, you'd be best suited to at least give some advice or information around that.
Sometimes when people are talking about their adrenal, it's actually very rare that somebody has something called adrenal fatigue. We don't really consider that a medical diagnosis. It's often a side effect of overtraining. And so when people do overreach or overtrain, they can just have an overall fatigue that requires actually complete rest to recover from that. It's not that just the adrenal is not working, it's that everything is sort of suppressed. So to truly have a dysfunctioning adrenal is a more serious diagnosis, and that's Addison's disease. But the adrenal not responding or the different hormones being suppressed are more likely related to overtraining or underfueling.
I can pick it up from here. Shona, just to confirm if you can hear me.
Still not here, Phatho. No, okay.
Right.
I'm sure she's heard you speak a couple times, so I'm going to pop up your slides and get you good to go. How's that, Doc? Phatho?
Perfect. That's perfect, my side, and I'm assuming that the participants can also hear as.
Yeah, I hope so. Maybe just let us know.
Next.
Let us know if you can't hear Doc Phatho, please, and we can just check that out. It looks like the participants can. Yeah, it looks like the participants can hear you. So I'm not 100% sure. Doc Kate, I'll get you back online now. Okay, Doc, if you want to.
Okay, that's perfect. Let's take it. So thanks very much, Kate, and thanks, Shona. Now we started this webinar series on the female athlete, about 3 weeks ago with the Coach Parry team. And what I would like to do now, as Shona mentioned at the beginning of our evening, is I'd like to pick up on a few questions that have come up or that we've received throughout the series that are specific to the topic of REDS. Now, Dr. Ackerman might have addressed some of the elements that I'll refer to when I answer these questions, but the following slides really are just going to provide some clarity on some key themes that often cause confusion if they are left unanswered. So first up, we asked the following question. We asked in tonight's poll, has your period ever stopped for more than 3 consecutive months for any reason other than pregnancy? And when I last checked this poll, there were about 30% of you, or 28%, it was just under 30%, essentially answered yes, it has. So I guess the next question goes, all right, if you were one of these women who fall into the category that answered yes, the question would be, should I be worried? Or if you're a parent or a coach of a female athlete who reports to you that they've missed their period or are getting irregular periods, you may be asking, is RED-S or REDS the only reason my child or athlete could be experiencing irregularities or menstrual irregularities? And so I just want to take you through some of the causes of amenorrhea, which is missed periods, so that we can start to address this question. Now, it's important to understand that there's 2 main categories of amenorrhea. There is what we call primary amenorrhea, which is essentially when you don't get a period by the age of 16. So Kate mentioned, or Dr. Kate mentioned 15 as an age, but basically if by the time you reach 16, you haven't had a period at all as a female, we'd call that primary amenorrhea. There are a number of causes for primary amenorrhea. Usually it's genetic or anatomical abnormalities and genetic sort of conditions like what we call gonadal dysgenesis. There may be certain chromosomal disorders like Turner syndrome. Many South Africans will have heard of DSD with the controversy with the World Athletics or IAAF right now. And of course, PCOS, so polycystic ovarian syndrome, is also a cause of primary amenorrhea. Secondary amenorrhea is the second category of amenorrhea that we refer to, and that's particularly what we mention in the context of REDS. So secondary amenorrhea occurs when a woman who has had a normal menstrual cycle stops getting a period for a period of 3 months or longer. And so this is the context in which I asked this question. Have you ever stopped getting a period for 3 months or longer? The reason being really, there's again a number of reasons that you might get secondary amenorrhea. In other words, that your period might stop or might become irregular. But if you skip your period for 3 cycles, that becomes a clinical indication for working up, all right? So again, a number of reasons that you could get secondary amenorrhea. Firstly, natural reasons, right? Natural reasons that shouldn't be a cause of alarm. So pregnancy, and this is why I said outside of pregnancy. Before pregnant, obviously you'll skip your period for 9 months, and possibly longer than that after pregnancy, of course, if you're breastfeeding. And another one that we spoke about in great detail last week was menopause. So we know that obviously when you enter perimenopause, your period becomes irregular, and then postmenopause, that's when you lose your period for 12 months and then you stop getting a period altogether. These are natural reasons, no reason for concern, unless of course you weren't planning on falling pregnant. But, certainly no reason for any further workup. Then the other category of causes that I'd call, when I say not natural, let's call it clinical reasons or medical reasons that one might then secondary amenorrhea. And these then reasons may or may not warrant treatment. So hormonal imbalances that are caused by thyroid disease, that are caused by changes to estrogen and testosterone, or pituitary gland illnesses or cancers. Using birth control, we asked the question, how many of you are on birth control? And I just want to see again what the answer, Shona, do you have a quick answer to that poll for me? So we asked the question, how many of you are on birth control? And we got an answer of, okay, now it's coming up. The poll is active right now. So about let's just call it 20. We'll call it about 20% of the respondents currently commenting that they are on birth control. And what you will know, depending on the kind of birth control that you're on, if you're using a hormone-based birth control, like the Mirena, like an intrauterine device, like Depo-Provera, the injection, that again, you might not get your period for a certain period of time. And that again, that's entirely induced. So again, wouldn't be a reason for you to be concerned, as long as you're aware that that might be one of the side effects of your hormonal birth control. The use of certain medications like chemotherapy or medications that are used to treat certain mental illnesses may also cause secondary amenorrhea. Structural issues, I mentioned polycystic ovarian disease. Also, sometimes certain medical interventions. So if you would have gotten a DNC to treat either a miscarriage or other kind of uterine problems, it may sometimes result in scar tissue that then also causes structural problems that disturbs your menstrual cycle. And lastly, lifestyle factors. So we've spoken about RED and energy imbalance, eating disorders, and of course we know that emotional stresses might also cause menstrual irregularities or skipped periods. All right, so now we have gone through a whole list of possible causes. The question then becomes, now what? You know, out of all this menu, how do I know what I have and what's more important and when I need to be concerned? So now, as I mentioned when I started, secondary amenorrhea, in other words, more than 3 months or consecutive months of skipping your period or skipping your cycle rather, requires a workup. Typically, this would start with a history, and Dr. Kate went through a nice little detailed slide about what kind of questions that you would ask in the history. And really, you're asking about symptoms that are specific to different causes. So in the history, you're trying to pick out any symptoms that would point you in a certain direction. You're asking if the patient has any medical conditions or is on any medication that could be causing amenorrhea. You're asking about lifestyle factors. And of course, if they're an athlete, you also want to get indication of training frequency, of intensity, and of energy consumption. Now, we also, of course, ask about sexual history and sexual activity, because if there's a chance of pregnancy, before you move to any physical or any complicated labs, what you want to do is you want to get a pregnancy test. Most doctors keep these in their office. Before you even move to a physical exam, you might ask your patient to go outside and do a urine test so that you can rule that out if it is a possible cause. Because obviously, if that urine test comes back as positive, then it leads you down an entirely different direction. And so the physical I'll do will be very different. I refer you to an obstetrician or a gynecologist, and I end my consult by having a good discussion with you about how to train safely in pregnancy and what you're going to do and how much you're going to do, and that will be that essentially. But of course, assuming that you're not pregnant, then we might go through another route. So we'll do a thorough physical exam. Again, now informed by history, we might be looking for certain things in the physical exam. And then depending on where that leaves us, we might do some blood tests, all right? And again, I won't go into a lot of details. Dr. Kate mentioned the ones that are specific to REDS, but of course, while we are still trying to exclude other pathologies, you might then do some other blood tests. And lastly, of course, there might be some indications to do some imaging. So whether it's a pelvic ultrasound, whether you're doing an abdominal ultrasound for other pathology, X-ray, CT scan, MRI, and of course, Dr. Kate mentioned a DEXA scan, which is what looks at bone density. But really importantly then, the treatment is entirely determined by the specific cause. So really, really important. The way I was taught medicine is you don't treat unless you have a diagnosis. Right? You can treat the symptoms, but then you're just brushing the surface. So really important to get to a diagnosis to understand what's causing your secondary amenorrhea and then direct your treatment towards that specific pathology. Also, it's important to have treatment goals, right? So your goals might be to relieve the symptoms of hormonal imbalance. It might be to establish menstruation. It might be to prevent complications, or it might be to achieve fertility. So understanding the treatment goals will also help direct treatment and perhaps specific interventions or speed of intervention. Now, another comment that came up in the series that was related to this, a lady mentions that she only started menstruating at the age of 30 years old. She currently gets 3 periods a year. She does have a child, but she's also had 2 miscarriages, and she currently has a stress fracture. This came up after, I think, last week's conversation. She consulted a GP, and she was advised to start the pill. I want to emphasize again that if you're a female and you previously were getting a regular menstrual cycle, if you skip your period for 3 months, you need a workup. Secondly, if you're a female and you haven't started menstruating by the age of 16, again, you need a workup. You need to understand why you have primary amenorrhea. So the lady who posted the comments, I'm hoping she obviously would have gotten a workup before the age of 30. And certainly as she then started to get these menstrual irregularities, that should have been something that leads her to, again, go consult and get a workup. And she did. She went to a GP. But sadly, this approach is not uncommon, right? Because symptoms of REDS are menstrual dysfunction, and some physicians do then recommend a oral contraception because the pill will regulate the menstrual cycle. But, and this becomes really important, if the underlying cause of the menstrual disorder is energy imbalance, then using pills to regulate your cycle without making changes to the training load, without making changes to diet, without making changes to behavior, it will just mask the problem and it will delay treatment, or the appropriate treatment rather, right? So all the complications that were mentioned, the mood disorders, the bone density issues, the other physiological, the cardiovascular risk, the hematological issues, that will still carry on. Because what the pill does essentially is you get a withdrawal bleed when you take that placebo. And so it's not your hormonal homeostasis, your physiological balance that's resulting in you getting your period. It's really just a withdrawal bleed, and it's a fake period, if I can call it that. So really important. The next really good question from Nicola, before I move on from this particular topic, the next really good question from Nicola, who joined our first webinar, she said, in fact, let me just move on with this one. Nicola then asks, can you have REDS and continue to have your menstrual cycle? Which is a really, really great question. Because with all this talk about amenorrhea, you very well may be excused for thinking that if you still have a period, then you're in the clear. All right. And the reality is you're not necessarily in the clear. And in fact, you could still have a period, but you could be showing the other symptoms of REDS. And I think Dr. Kate did allude to this a little bit. Usually as a female, by the time that you are experiencing a combination of these symptoms, and so again, we spoke about disordered eating, fatigue, hair loss, the cold hands and feet because of what the lack of estrogen does to your cardiovascular system, and a lack of vasodilation, dry skin, your weight loss, recurrent injuries or prolonged healing time from injuries. By the time you're experiencing a combination of these symptoms, usually as a female, you would have some kind of menstrual disturbances. It might not be a frank amenorrhea, so that you're not getting your period at all, but it might be subtle. So you might be getting a delayed period. You might be getting spotting. You might be getting shorter periods, or you might skip your periods. Again, you might still get your period. Why? Because you're on the pill. And if you're on the pill, as I said, when you hit that 7-day placebo, you just get a withdrawal bleed, right? So really important to know that you still might get your period. And then, of course, let's not forget that energy imbalance does also occur in men. And so I know we're speaking about females right now, but if we just focus on the period and ignore every other symptom and all the other signs, then we may miss this important diagnosis. So just to emphasize, can you have REDS and continue to have your menstrual cycle? The short answer is yes. And I think that's the purpose of this webinar, is that yes, for females, often one of the early signs, one of the signs is menstrual irregularities or disturbances, and absolutely an absence of a period. But it's really important that you also know and are aware of some of the other symptoms so that you can have an increased sense or heightened awareness and again, direct your queries and your concerns to your doctor so that they can look at the full picture. I think Dr. Ackerman, the first slide she showed that there's the one extreme and then there's a continuum. So I think it's important for us to be aware of what can happen on the continuum of the symptoms so that we can flag it early. Next question, and it's come up again today in today's webinar, can REDS affect menopause? Now, Shona, there's going to be a time here that I'm going to ask you to bring Dr. Ackerman into this question, because this is a fantastic question. I think it was asked by 2 different people in the previous webinars, and I know the question came up again. Tracy asked, will REDS affect her after surgical menopause? And I know that, yep, and Nikki also asking, how would you tell the difference between amenorrhea due to REDS or menopause? So really, really excellent questions. Fact though is, because the female athlete is relatively understudied, I think Dr. Kate mentioned that this research essentially started in about the 1970s or 80s, but because the female athlete is relatively understudied, I actually couldn't find any articles that speak to this particular. So in other words, the interaction between REDs and menopause. And I will pull in Dr. Kate here because she's certainly has got a significantly greater amount of experience, especially in the research aspects that I do in this particular age.
Well, let me.
I'm going to draw on logic.
Okay, no, that's fine. I was going to say, because I'm the only one who can speak to Kate in this little three-way that's going on yet. So let me know when you want me to bring her in. And maybe if Kate can hear me, because I try to send her a message.
So let me draw my
Doc, I was just going to say, Doc Kate, if you try log in and out, it might be a connectivity issue on your side. So maybe just try that, and then we'll pull you in to answer this question as well then. Okay, cool. Doc Phatho, fire away. Thanks.
Okay, super. So really great question. Let me try and apply my logic here. So if I keep it really simple, we know that the REDs, through its influence on that hypothalamic axis, does decrease the production of estrogen, right? We know that. We also know that one of the main hormone changes that occurs during menopause, ultimately at the end, not during perimenopause, but the end, is a significant reduction in estrogen. So in theory, my answer would be yes. In terms of estrogen levels, what you would experience is you'd experience a double hit, okay? So if you have REDs before menopause, ultimately, remember what we're saying is that leads to decreased estrogen. And in terms of bone health, at least, you'll already be experiencing complications and compromise on your bone health. So if you have REDs before menopause, then you would enter menopause with a lower baseline of estrogen levels and therefore a lower threshold in terms of bone health. The effects of reduced estrogen after menopause would also be worse on bone health, right? Because again, you're working off a lower base. Then, because some of the symptoms are similar, so REDs and menopause, fatigue, mood disturbances, decreased libido, menopause could mask the symptoms of RED and vice versa. So REDs could also mask the symptoms of menopause, right? I should have put the slide up earlier so that Dr. Ackerman can actually read this and then give her input as well. So at this point, Shona, please, I'd love to hear her input. Also love to hear if there's actually any studies that speak to this.
Did you hear all of that, Doc Kate?
I don't know what that was about. I was reading your slides, Phatho. I assume you said great things. So I don't think there are a lot of studies about menopause. This is kind of the frontier that I think we're getting closer to menopause are excited to study because it's so much of an unknown. I definitely have friends who kind of struggled with REDs and didn't know what it was and were told that they were in early menopause when they really weren't. So there's such an overlap here. We definitely need to be studying it more. But just looking at the different chats over at the side, somebody asked if people can be underweight and still running well. That is one of the things that we see. Often people will be underweight, running well, have REDs, and not fallen off the cliff yet. And so they haven't had all these health effects. And then they get a little bit older and they start getting injured and then they lose their cycle and people start telling them it's other things like, oh, it's just you're a runner. Or, oh, it's because you're getting closer to menopause. And so it can be misdiagnosed a lot.
Fantastic. So again, I think the emphasis really being that clearly an area that's understudied, a lot of opportunity for research, and that's why you have people like Kate in this field. You have, in fact, myself, who's now delving into this from a South African level because we've got nothing, no research coming out of South Africa from this. So I guess really exciting in that we're going to learn more in the near future, but unfortunately, we can only draw on logic in answering that question. Then the final question, I think, before we actually take some real-time questions from today, final question was, if estrogen is so important in the context of normal physiological function and both bone health, shouldn't we all just be taking hormone therapy? That was a question following last week's conversation on menopause. So in the past, we know that hormone therapy was widely used to relieve symptoms of menopause, specifically hot flashes, the night sweats, the vaginal discomfort. And the use of hormone therapy is also indicated for conditions like premature ovarian failure, primary ovarian insufficiency, which causes early menopause. So that's surgical menopause, that somebody mentioned earlier, I think having had a hysterectomy and a double oophorectomy or removing both ovaries. So oftentimes, especially if this happens quite early, so in your 30s or 40s or even younger, then that might be a clinical indication for using some hormone therapy. And the other reason, of course, is usually to prevent osteoporosis. But it's really important to note that there are risks of hormone therapy. And the risk depends on the type of hormone that you use, the dose that you use, and how long the medication is taken. It's also really important to consider a person's individual health risk. So the answer is not simply that everybody should be taking hormone therapy. Rather, if it's clinically indicated, then you and your doctor should weigh up the risks, the benefits, the alternatives to treat those symptoms or those complications that you're trying to manage, and then make a decision that is based on the collective discussion. So Shona, I think I just want to end by saying that today's key message to everybody listening in on this webinar is just be aware. Be aware of the problem that potentially exists with the red or energy deficiency and the various signs and symptoms. The purpose of this webinar is certainly not to make the participants paranoid at all, but we know that knowledge is power. So if you're aware of the risk, then A, you can prevent the onset. And if you're aware of the different scope of symptoms, then B, you can get early treatment and prevent complications. Let's leave it from there, Shona, and then perhaps take some questions.
We're definitely going to jump into some questions now, but I think that's exactly it. You know, when we did that first webinar about a month ago around, and I think we were so excited to dive into things, but we asked, you know, how many people had even heard of REDS, you know, and so that's the goal here, is just to start empowering women with this information. So exactly like you say, they can start doing the right things within their training. So I'm going to pull up a couple of questions and I'll direct them, to both of you, or as they come up. So there's a question here from Sharon. Sharon is saying, I had a physical breakdown last year, total exhaustion, all hormones were zero or low, including thyroid. Treated with hormones and thyroid. Was that just REDS, or was that overtraining, or what was it? And I know that's always difficult to answer without having a history, but maybe Doc Kate, maybe can I direct that one to you, and then Doc Phatho, you can also add in there.
There's a lot of crossover in terms of what is REDS and what is overtraining. That's an area that a lot of people are trying to differentiate. Certainly, if everything was suppressed, taking the foot off the gas is the way to go. Definitely rest and increasing fueling to see how some of those hormones are responding. Having a low estrogen level can be from various things, but there are other hormones that you can check to help determine why Dr. Phatho is saying. So basically, if you have an elevated FSH but a low estrogen, that is menopause. If you have a low FSH and LH and low estrogen, that is likely REDS. So to have everything suppressed all at once, that is usually more indicative of a low energy availability state.
Brilliant.
That's the only thing that I would just add there as well. And it's when I'm with students, they get tired of me saying this, but it's really important to get a diagnosis. And if you can't do it yourself, to refer to somebody who can and who can help you with that diagnosis. Sometimes the presentations are really tricky, so certainly not just reflect to the initial clinician that will see, because I mean, I've had many patients with me, and in the first consultation, it's not clear what's going on, but you need to just dig a little deeper until you have your why, because then you direct your treatment there. If it doesn't work, then you know you look elsewhere. But you sort of don't shoot with everything that you've got in your arsenal.
Thank you for that. Caroline's asking a question, and I know we are doing a full-on nutrition webinar next week, and so it's following on quite well from this low energy availability sort of discussion, but I'm going to ask this question now. Caroline's asking, how important is refueling promptly after a long or hard run? If you don't, could it lead to similar problems with bone health?
So I'm happy to start perhaps with that answer.
Yeah.
We know that refueling, again, it'll be probably like something that you hear, a hymn that you hear from a sports physician or even your physiotherapist or coach. We know that refueling is really fundamental in terms of recovery, really important. So in terms of sustaining performance, recovery, and certainly building on performance, when you refuel, how you refuel, and with what you refuel, so the quality of your nutrition becomes really, really important. Obviously, that just depends on the intensity and the, of exercise and training that you did. You go for a nice casual 30-minute walk, you might not need to refuel with the same kind of focus and intensity as if you were running a marathon, because obviously that we know that physiologically the strain that your body went through after a marathon or during a marathon requires a lot more attention post-marathon than it would after a 30-minute walk. So to answer your question, really important. It's important to have the right combination of carbohydrates, protein, electrolytes, and fluids. And usually we say that within 30 minutes or an hour, especially after an intense training session, would be sort of optimal in terms of doing what needs to be done.
And we definitely will get into that with Nikki, who's our resident dietitian, next week. And I guess maybe practicality around, we're talking low energy availability, and we say to people, well, you must, perhaps eat more, but that's not always just a plain answer. So yeah, be sure to tune in next week, because we will dive really a lot deeper into essentially the nutrition side. Laurel, in the beginning, she asked us quite early on, she was saying, what about low energy levels post hysterectomy? So when her ovaries remain. Is that related to RED? How is that somehow related?
I mean, a hysterectomy, basically, if you have the ovaries, you can still check hormone levels. So the hysterectomy just means that the uterus was taken out, but it's not an oophorectomy. So if somebody is premenopausal, yes, they won't know that they're getting their menstrual cycle, but we can check hormones to determine if their hormones are in a normal range.
Okay. Brilliant, thank you. I'm just going to click onto this next slide in the meantime, and just let people know if they're wanting to hear about the next webinars, and that is on the page, and the link is there, and Doc Kate's and Doc Phatho's Twitter handles are there as well. We are going to dive into a couple more questions. I know I have two extremely busy physicians with me, but I am going to squeeze a couple more out of you guys if that's okay. Let me just find that one I had. Angela, go ahead.
I was going to highlight one, I think. Again, probably that will be delved into a lot more detail next week. But speaking to fueling before, so coming from Mona saying, I find it really difficult to fuel before a run. I have a severe GI response. I know that this is commonly reported amongst runners, and then you have to go and look for portaloos, which is really not pleasant. During a run. So question really being, what do I do then? And I know Nikki can go into great amounts of detail. Again, depending on the intensity and the duration of exercise that you're going to participate in, it does become really important to fuel. And there's a few strategies that you need to play with. We always say that you must train your guts the same way that you train your muscles for a race. So again, it might be, having your, I call it pre-match because I sometimes work in rugby, but having your pre-race fuel, timing it so that it's about, a bit of a distance away, 2-3 hours. I know when we're running marathons that start at 6 o'clock, it becomes impractical to wake up at 2 to eat. It might also be like changing the quality of food, the specific fiber or intake, so that it doesn't cause the same amount of GI irritation. Nikki will probably have a detailed conversation about sucrose and glucose and sort of the different forms of carbohydrates and how they irritate the GI. But I think fundamentally, this is very much a valid concern, Mona. But again, consulting a dietitian might help you understand a few tricks or alternatives, rather, that you could then try that would at least give you the energy that you need to sustain your efforts throughout the run. Because we know that if you're running a marathon, you're not going to be able to do so effectively and perform at your best on an empty stomach, or if you haven't got, again, the right amount of carbohydrates, electrolytes, fluids going into the race. Shona, you probably will to expand on that more as well from a coaching perspective.
Yeah, definitely. I think that the training the guts bits is really, really key. And I think managing or we almost say periodizing your nutrition as well. So whatever sort of aspect you're training, you want to be able to be fueling for that specific training. So if you're doing a high intensity training session, you want to be sure that you're definitely fueling for that session. And you can periodize your nutrition according to that, as opposed to, and again, that's about training the gut, making, it's got all to do with the physiology of the running there as well. And so, yeah, definitely. We'll definitely be diving into a lot more of that next week as well. Great. So I'm gonna jump into a question here from Angela, and Angela's asking: last summer I had low iron and high creatine in my blood tests. Are these related? Oh no, wait, sorry, I already asked that one. Apologies. That's not the one I wanted. There's another one. Sorry, enough. No, I lost it. Oh, there we go. Sorry, it's from Concelia. It says, I have iron deficiency and I'm on treatments. If I miss one day of treatments, I'm unable to breathe during training. What do you think could be the cause? Again, I mean, these are tough questions to be diving in straight away. But is the iron deficiency related somehow with? I know you did touch on a little bit, Doc Kate.
So it has to do with iron stores and the fact that your red blood cells need iron for oxygen carrying capacity. So I don't know what this person's iron stores levels are. So there are different things that you test in the blood. You check ferritin, you check total iron level, you check the percent saturation, so how much the receptors are saturated with iron. So it may be possible that this person continues to be a little bit iron deficiency and they're kind of living on the edge there and don't have enough stores. So I would encourage them to get more lab work done and follow up with their doctor.
Okay. Great stuff. And then this is a great question from Robin, and I know you did touch on it, Doc Kate, but I think it's just so important. Robin's asking, what should we be encouraging our young athletes to do or to eat while in the adolescent phase to improve their bone health and set them up for the future while still maintaining their ideal weight for sports?
The statement there is ideal weight for sport. I think we have to get away from this concept of what an ideal weight for sport is. It's really the ideal weight or the optimal weight for that person. And we certainly see people of all different shapes and sizes excelling at sport, and it's what works for them. So it's the problem saying that this is exactly what you need to look like to be a high-level runner. And then you could be surprised. There are people that look much differently, that are much healthier, that are actually doing extremely well. So I think to emphasize skill acquisition and proper habits during adolescence, that's the most important thing, so that we're not forcing people into a small frame and having them lose their menstrual cycle and not accrue their bone density during that really important time of adolescence. So we want them to feel enough that they get their period, they get it every month, they're getting calcium and vitamin D, and they're getting enough calories in that they're able to maintain that through adolescence and adulthood.
Dr. Phatho, you want to add on anything there at all?
I think that Dr. Kate made a really sound point around the ideal weight. And maybe perhaps just to expand then, when we do come, assuming we've taken care of that, when it comes to the different kinds of food, I think where Robin, to make sure I get the question right, Robin raises a really good point, is that you're very correct in saying that it is in the adolescence, sort of up to the age of 30, 28, I should say, that that's when we maximize our bone health. So it really is an important period. Dr. Kate mentioned calcium, vitamin D, and of course it depends on the diet that you follow. So we know that, dairy products are said to be good in calcium. We know that certain fish like canned sardines and salmon are also good in calcium. Certain veggies, the green veggies, kale, turnips, certain cabbages are also really good. Broccoli, good for calcium. Vitamin D, again, available from salmon, mackerel, but it depends on your diet. So I think here's where consulting a dietitian who then understands your dietary preferences, if you're on a specific diet, will then be able to accommodate for that and ensure that you do get the right macro and micronutrients.
Yeah. I will have my little 2 cents following on from the two doctors, but what Doc Kate said about this idea of ideal weight, and it drives me absolutely mad when I'm watching track or athletics or any sport for that matter on TV, and that is said, well, she's very strong for her height, or she's very lean, I think we have to be a part of that. That's changing that social construct around the language that we use, in particular when we're referring to female athletes, but it does also happen within a male athlete realm as well. And so I think just that would be one of the things that I'd also focus on with the young athletes, is focusing on just changing that social construct so that it's moving away from this idea of ideal weights, essentially. That was just my last little 2 cents there. Okay, there are 1 or 2 more questions coming in, and so I will. There's 3. I'm gonna ask 3 questions, and then we can call it a night. There's one from Sharon saying, how does digestive problems like IBS affect REDS, or having a REDS problem? So I think she's probably getting along the lines of, proper nutritional intake. Doc Kate, if I can direct that at you.
I think a lot of times it's hard to tease those diagnoses out. So certainly in the anorexia literature or extreme low energy availability, we can see that people actually get irritable bowel, and some people have constipation or even diarrhea that can go hand in hand with restrictive eating patterns. But then as you're trying to get someone to refuel, they can also have some GI issues. So a lot of my patients, I share with GI doctors who can help them figure out how to get through that. And then if you have a different kind of inflammatory bowel situation, so if you actually have something like celiac disease or another type of disease that's causing an abnormality in absorption, that's going to possibly lead to REDS, because people just aren't getting the calories in or the nutrients they need because of that underlying GI process. So it can be tricky, but it requires kind of a multidisciplinary approach.
Brilliant, thank you. And then Lesejo is asking, Doc Phatho, I can maybe direct this one to you, and Doc H, you can add on as well. Lesejo is saying, I had irregular periods around March. And then I was diagnosed with kidney infection. Pregnancy test was negative. Same thing again now. 2 negative pregnancy tests and still no periods. Low energy and frequently signs of flu and headaches. Do I have red S? I know you can't give that answer right up, but perhaps if we could advise Lesego from there.
Sure. So I'm happy to go first here, and excuse my background noise. My alarm clock of a 2-year-old is going off right now. But no, I think you're very correct to be concerned, and I think you're very correct to have consulted a clinician or a doctor to investigate and to find out what the underlying cause might be. If we've excluded pregnancy, you saw that big menu of some of the conditions that can cause amenorrhea or menstrual disturbances that I put up. And so I think it is important to then essentially have an approach to working your way through it. The first thing first is to take a thorough history. So you've mentioned some of the symptoms or signs that you've got, but also obviously if you're sitting down with your GP or a sports physician, they'd ask a few more directed questions. So common things occur commonly. We might have excluded pregnancy. What else might be? You'd look at things like polycystic ovaries, and if you've got some signs and symptoms there. Certainly from a REDS perspective, if you are an athlete or if you train regularly, I'd take a training log for you. I'd want to understand how much you train, your intensity. I'd also want to understand sort of your energy intake, as we've discussed before. And then, of course, I'll also direct my questions to some of the other clinical causes of secondary amenorrhea to ensure that I don't miss anything there. If I still don't have any answers, or hopefully at least my history will sort of direct me to a certain, at least differential diagnosis, which in other words, I'd have a top 3 from the history, then I'll probably do some investigation, some labs or some bloods to then try and see if I can confirm or exclude some of those, right? And again, the bloods that I'll do there would be very much determined by what are my top differentials. We have mentioned some common ones that we do now. If you're talking about relative energy deficiency syndrome, we speak about FSH, estrogen, and LH. And we know that if all of those are suppressed, then maybe it leads you in that direction. But of course, it's in the context of a history, and then these labs, a physical examination. And then, of course, if it's still further indicated, you might then get some imaging done. So whether it's an ultrasound, if I'm thinking maybe polycystic ovaries, if I might get some x-rays done, or I might get a DEXA scan done if I really am thinking it might be REDS and you might have complications.
Doc Kate's nodding. I think she's happy with that. So I'll just pop onto the next one. So I think, Hasina's asking around nutrition, and I don't really want to go too much more into that because we will cover a lot around the differences between men and women in next week's one. And then there was one around a training one, which I perhaps just want to say there was a lady who was asking around training and how she's struggling. She was worried that she wasn't going to make her marathon. And again, I just think that these things are never just one component. So we're talking REDS now for sure, but I think there's many other training aspects that we would need to dive into to really decipher these things. So it isn't always REDS, essentially is what I'm saying, is that I think there's lots of other things that we have to always consider as well. Okay, and then the last question is from Hasina. She's saying, I've got my periods again after 6 months. Is it safe for me to start increasing my weekly mileage again? She's obviously a runner.
I didn't see Hasina's first question, but perhaps I would want to know what the cause of her amenorrhea was, and I keep on going back to that. So assuming that we've treated the underlying problem, there was energy deficiency and she started to get a period back, obviously there's a way in which you're going to step up the training. And if you're going to step up the training, you need to make sure that you are appropriately stepping up the energy consumption. So again, the quality of food that you eat being more important than sort of the absolute quantities, but quality and density being really important. If there was another reason for her periods going away, so the secondary amenorrhea, then obviously it would be important to establish that has been treated from a medical reason, despite the fact that her period, that menstruation or cycle has come back.
Brilliant. So now, yeah, I think that's the combination there again. Doc Cates mentioned that around this like disciplinary team, and I know everyone doesn't have access to all of those things, but to have a coach that guides you in that return to play and that progressive structured return, I think is key. And like you say, mentioned in conjunction or in relation with a nutritionist, and so you're balancing those out. I think that's vital. So, okay, Doc Kate, maybe if I can hand over to you, your parting shots or anything you want to leave these Coach Perry runners with. That essentially we bombarded them with a lot of science and information tonight, but yeah, maybe some parting shots from you.
aware of these issues. And as Dr. Phatho has been saying, it's important then to bring it up to your doctor and to bring it up to people that have the expertise and the training. So rather than just trying to guess, going to your physician, going to a dietitian, bringing it up to the coach and trying to get more information so you're really knowledgeable rather than trying to self-diagnose and muddle through and feel like you're just not doing your best.
Brilliant. Thank you. Dr. Phatho, thanks again for joining us, and then your parting shots for tonight.
As my dad always told me, prevention is better than cure. So really important now that you're aware of the risks and what might put you in that category of female that would be at higher risk for energy imbalance or energy deficiency rather, just maybe making sure that you manage your circumstances entirely so that you prevent onset of energy deficiency. And then of course, just having increased awareness would make you diagnose or more sensitive early on if you are going down that road, and make sure that you get early intervention. There are many clinicians available throughout South Africa who could help you. Just go to the right person, in other words, a specialist or somebody who knows and can understand the dynamics of your lifestyle.
Excellent. Thank you. Yeah, again, thank you both for your time. Dr. Ackerman, I mean, yeah, Dr. Phatho seems to be becoming a regular on these, but Dr. Ackerman, it was really, yeah, we're very honored to have had you, and I know you are extremely busy, and so we really appreciate your time. Dr. Phatho, that doesn't mean we don't want you back either. We love having you, and so thank you for your time as well. Yeah, and for all of you who have been joining us, I mean, I really hope that you got some value out of this. If you do have more questions, please pop them onto that YouTube page, and we will try to answer as many as we can as we go along. And as we've mentioned, there's a little click there button for the nutrition webinar that's happening next week with Nikki de Villiers, who's our resident dietitian. But yeah, thank you both doctors for your time. Really appreciate it. And yeah, have a good rest of your day and good rest of your evening on this side. Thank you so much.
Thanks, everyone.